Good afternoon, everyone. Welcome back if you've been with us for the day. I'm Kate Warren, Executive Vice President, Executive Editor at Devex, and we are really proud to be partnering with MSD for Mothers on this important event around maternal health. I think probably if you're in this room, this is something near and dear to your heart, and we have really enjoyed our long partnership with MSD for Mothers to make sure we can bring these important conversations to the Devex audience and to moments like this. So we all know the urgency. Every 7 seconds, a woman or baby dies due to complications during pregnancy or childbirth. And really, we know that this is avoidable, preventable, and there's just really no excuse. So while we have been making strides, we have stalled many places, even regressed in others, and amidst what is a challenging financial climate, economic climate, some real challenges for the health system, really making sure that maternal health is a priority is what we are going to be discussing today. We have a great hour full of some really good conversations, some great experts and leaders here, and we're really excited to be able to welcome you all for this, our last conversation of the day. And I would like to welcome Jacqueline Caglia, who's the head of MSD for Mothers, to just welcome us and set the stage for the conversation.
Good afternoon, everyone. Thank you so much for spending a little time with us today during what has been a very busy and productive week here at the 78th World Health Assembly. We're so grateful to Devex for hosting this conversation and to all of our colleagues collectively contributing to the Every Woman, Every Newborn, Everywhere effort for their partnership. As Kate said, my name is Jackie Caglia, and I sit on the Social Impact and Sustainability team at MSD, where I have the pleasure of leading our company's global maternal health initiative, MSD for Mothers. Since 2011, our company has been investing in solutions to improve maternal health outcomes, to strengthen health systems, and to help create a world where no woman has to die while giving life. Whether you are here today as an honorable minister, representing a UN agency, a philanthropy partner, nonprofit organization, professional association, whether you're an entrepreneur, a student, or another private sector company, the world needs our partnership. During this session, called Maternity Matters, we hope to demonstrate that the health challenges that are facing families around the world related to pregnancy and childbirth are solvable in our lifetimes. We have made some progress to date, and with focused action and an eye on 2030, we can deliver for women and for future generations. We really hope that you leave today's hour-long discussion and this whole week inspired by the opportunities ahead of us and inspired by the opportunities that each of you have to contribute with your compassion, with your courage, and with your creativity on the path ahead. I look forward to the conversation. Thank you.
Great, thank you. Well, I will introduce our global health reporter, our editor, Rumbi Chakamba, to lead our next conversation. Rumbi.
Thank you. And we want to jump straight in, so I'm going to call our first group of panelists, Dr. Anshu Banerjee, who's the Director of the Department of Maternal, Newborn, and Child and Adolescent Health, and Aging as well at the World Health Organization, and Dr. Lisa Ngochu, who's the Director of Maternal and Newborn Health at JPEGO. Please join. So Anshu, I want you to kick us off. The United Nations recently released new estimates on maternal and newborn mortality and stillbirths. Could you share some key findings with us and maybe explain what is holding us back?
Thank you very much for that question. And I think everyone knows sort of what the data have highlighted, that there's been tremendous progress since 2000, but since 2015, there's been stagnation. In some cases, no progress. In some cases, even the figures have gone worse. And when we look at that, we should also keep in mind that there is not only well, there are global differences, but there are differences within regions, there are differences within countries. And if we really want to achieve the SDGs, it's important that we also look at subnational differences, and particularly to look at equity issues and which populations are really far behind. I think that if we really want to achieve the SDGs, we need to focus on those populations. And this week in conversations with many of the ministries and countries, we have heard that that is what countries are doing, focusing really at subnational level, identifying where are we making the least progress and how can we actually increase our investments at that level. The other thing is two components. One is around health systems and to ensure that health systems actually are able to deliver, really looking at a primary healthcare approach. We've heard very much, around how to strengthen primary healthcare. And at the same time, also in many countries, we'll have the social determinants of health that are holding us back, let's say, in achieving those targets. And particularly, I think at community level, we should also look at what are barriers at the community level in order to be able to address that. So, and these two factors, of course, lead to quality of care and how to ensure that quality of care is achieved. Access is not enough. Without quality of care, basically universal health coverage is an empty promise. And it's important for us to be able to look at the different building blocks that contribute to quality of care. So whether that's availability of commodities, having enough health work staff, having the data in order to actually identify the action that needs to be provided, and also the financing, of course. So keeping that in mind, I think also looking at how the private sector can contribute to delivering quality of care and investments within that. So again, leadership by countries, strengthening their capacity to engage and take that leadership role. Let me stop there because I know it's a very short panel and we'll come to some of the other points maybe later. Thank you.
Okay, so Lisa, we're going to jump to you. I know that JPEGO is a strong partner in this space. Can you tell us about the work that you do to support frontline health providers to strengthen maternal and newborn health?
Sure. First, I just want to thank Devex and the organizers, really Devex, for the important work that you've been doing over the past few months to shine a light on so many critical issues. So JPEGO and I are about the same age, I think, maybe a little over 50 years old. So we've worked closely with country governments for over 50 years and the private sector in many different ways to support health workers to provide quality maternal and newborn health services. And while we started primarily as a training organization in family planning, which in itself is a very important area for maternal and newborn health, we quickly moved into co-design of quality improvement strategies, mentorship programs that could be sustained after projects and programs end, and support for local professional associations for midwives, physicians, nurses, et cetera. And we've worked with frontline health workers in a lot of humanitarian settings as well, which still remains critically important because that is where the large majority of maternal and newborn deaths are occurring, over 60% of maternal deaths. And we've also worked with WHO very closely on the pathway from evidence to practice, guideline development, and translation of guidelines into tools and strategies for health workers to use to make delivery safer, putting health products in the hands of midwives and making sure that they have the skills to use them. And today we're working globally in over 33 country offices and using a range of contemporary tools to help health workers create really high quality maternal and newborn health services. So simulation, group antenatal care, AI, midwifery-led models of care, collaboration with families on novel ways to provide postnatal care and self-care strategies, the surgical safety checklist for safe cesarean birth, fistula repair, and support for the mental health of health workers, which is a really critically important, but unfortunately under-resourced area now that I think came to light during COVID, but really has gained more prominence over recent years.
Anshu, Lisa spoke about how JPEGO started with training. As we look to equip providers with training and tools needed to deliver quality and equitable care for women and children, how can strong leadership, data, and strategic collaborations help strengthen healthcare systems?
So leadership, of course, key. And I think for many of the low-income countries that have this, and basically sub-Saharan Africa is where most of the high-burden countries are. They have, of course, now the Lusaka agenda that really is putting the leadership at the country level and encouraging countries to take that leadership role and ensure that partners will align to their agenda. And to support that, we have a couple of WHA resolutions. Last year, we had the resolutions on accelerating progress to reducing maternal and child mortality. That really galvanized, I think, a lot of the partners to reinvigorate the advocacy around this agenda. This year, there's going to be a proposal to ensure that World Prematurity Day is going to become a WHO recognized day, and hopefully that will be endorsed Friday afternoon. But that resolution also includes a lot of programmatic elements that we're asking countries to sort of take forward, as well as partners, and how they can support it. Secondly, of course, we've just seen in what happened over the last couple of months that data systems in many countries are crumbling, but at the same time, it's maybe also an opportunity for countries to take that leadership and to ensure that they own all the different data systems that have been set up at country level, and really own the data that they have in order to be able to take the programmatic decisions that I think, a negative consequence, let's say, the investments that have happened, but at the same time, an opportunity for countries to take on that leadership. The other thing, very important, I think, is to strengthen partnerships. And again, here, the leadership role of ministries, strengthening partnerships really at local level, subnational level. WHO came out with guidance on networks of care, really looking at the relational working relationships, let's say, between different institutions, and how can we ensure proper referral? How can we ensure that from the community to the district level, there's a pathway that patients can follow that is as seamless as possible. At the same time, of course, at the national level, leadership from national governments in strengthening the technical working groups around RMNCH. Of course, regional initiatives like the African Union, other political bodies, in order to raise the profile of RMNCH and achieving the SDGs by 2030. And of course, at the global level, we have partnerships like the Every Woman, Every Newborn, Everywhere that Jackie just alluded to in her introducing comments. So that's important. And some of the crucial issues to look at, I think, are, again, data, commodities, health workforce, many of the systems issues that we need to address. And our interest and focus, of course, is to make those systems deliver for RMNCH.
And Lisa, you've spoken about some of the collaborations that you've had. Can you also tell us why it's important to have strong leadership data in these collaborations?
Yeah, sure. And I'll actually start with a quick story because Anshu mentioned networks of care, and that is something that we've helped to introduce in partnership with a county government in Kenya. And they had a situation last year where a woman was experiencing a life-threatening ectopic pregnancy, and the surgeon didn't feel comfortable managing it on their own. And so because there was a network of care in place and there were really some strong relationships among facilities, another surgeon, we didn't move the woman to another facility. We moved the surgeon to the facility where the woman was.
So convenient.
So, but these kind of collaborations really are so important. I want to contrast that with a hospital I visited last year where they traditionally, this country had received a lot more HIV funding as compared to maternal newborn health funding, but their maternal newborn health indicators are challenging. And when I was visiting the hospital, I was surprised to see it not so packed with families, because the last time someone from our team had been there, it had been absolutely packed. And so I asked the midwives, because that's what you do at a hospital when you want to know what's going on, you ask the midwives, where is everybody? And they said, well, the word has gone around in the community that we have run out of oxytocin and the women are no longer coming. And so that, I see Anna, I see other midwives here, that's terrifying for us. When we think about having to provide care without the right tools, products, strategies in our hands, but that's the reality of many health workers now. But I think we do see some promising signs today, this afternoon, actually. There are many funders who are actually coming together in a collaborative workshop focusing on maternal health products and increasing access. So SIF and GFF, Gates, Unitaid, others, they're coming together in a way that hopefully there's going to be some strategic collaboration to help cover gaps in access to maternal newborn health products. And I find that very encouraging.
Good you mentioned money, because I feel like we can't have any conversation at this WHA at this moment in time without talking about money and funding. So how do you guys see us navigating this current funding challenge, especially in low and middle income countries? I'm sure I'm going to start with you. And unfortunately, I only have 1 minute. I know it's a tough question.
No, I think we know that compared to 2023, there's going to be a 40% reduction in external development assistance for health, let's say. So countries will have to step up their domestic resource mobilization. How can they optimize the service delivery? Integration of care is going to be crucial. We know that many of the programs were still vertically funded and had like parallel systems with healthcare workers, commodities, etc. So that integration into a primary healthcare system is going to be crucial. We did a survey as WHO, and from 108 country offices, we know that there's already been 50% or 70% of countries have said that, you know, there's going to be a reduction in service delivery provided. And how can countries really identify where they need to scale up the high impact interventions that, you know, are really cost effective, and how to target those? We have already conducted in a number of countries the maternal newborn stillbirth transition framework that really allows countries to identify geographically where are the gaps, but also looking at the interventions where are those gaps, and not only programmatically, but also looking at health systems, looking at multisectoral engagement, and looking at broader issues at community level as well. So there are tools available now for countries to really identify how they can address this funding gap and how they can prioritize the services they need to put in place.
Lisa, your recommendations for this tough period we're in?
I think, you know, over the past week, we've heard health ministers themselves and their senior staff really shine a light on the fact that it is time to pause and listen to country priorities. And this isn't new. This is, you know, Lusaka, the agenda. This is before that as well. And I think some of us may have heard this minister for, I think it was statistics and research for Nigeria, who said, if you come and you don't align with our priorities, keep your money. And that was very striking. And I think it's something that the community needs to hear as funders come together, implementing partners come together. Everyone who wants to do good and be helpful needs to listen to that. It's a really important moment for that. I don't think any country should have to choose between accepting assistance at this really difficult time and aligning with and choosing and declaring and going forth with their own priorities that they know are right to take care of women and families in their countries.
Thank you so much, both. You've given us a lot to think about, and I am going to release you. Okay, moving one chair down for our next conversation, I'm going to call on stage Dr. Ayman Abdul Mohsen, who's the Chief Sexual and Reproductive Health and Rights Branch Program Division. I feel like I skipped a word in that, at UNFPA. And then Dr. Rhonda Seeley Thomas, who's the Assistant Director at PAHO, as well as Anna Ugles, who's the Chief Executive Officer at the International Confederation for Midwives. Okay, I want to start this off a little differently. We've heard a little bit about the every woman, every newborn, everywhere initiative. So we've been having a little internal debate here. How do we say this? Is it supposed to be EWENE, or is it supposed to be EWENE, or do we just spell it out? So let's have a little bit of a vote to relax us here. Anyone who's voting for EWENE? Am I saying that right? Whoever proposed this, EWENE. No one? Really? Just really? I thought the other one sounded more African. Okay, what about EWENE? EWENE, or is it EWENE? EWENE. Okay, so we're gonna stick with EWENE for this, and no one wants to go EWENE, right? Okay, consensus, EWENE. So, okay, so Ayman, Jackie talked about EWENE. She alluded to it when she was speaking, and it aims to support countries to accelerate maternal and newborn health by 2030, I'm sorry. As new partners begin to collaborate with you, what expertise and assets will be most impactful to reach your goals?
Thank you very much, Rumbi, and good evening, everyone. And I also would like to start by thanking Devex and MSZ for Mothers for bringing us together and for the good support that we are getting and the good partnership. Because it's all, I think, to answer your question, Rumi, is about the partnership. And EWENE is a partnership. And I have the privilege of co-chairing this partnership with our colleagues from WHO and UNICEF. And I think it provides us with a vital technical leadership to make sure that our efforts are coordinated and collaborative enough to deliver impact. So this is where I believe that EWENE as a partnership, as a platform that invites in our technical and program partners and our political partners and our supporters to be able to deliver management and measurable impact at the country level. This is the importance, especially in during these days that we're going through with the funding situation. I don't want to repeat what Anshu has mentioned. We need to be working together in coordination and not in parallel. We need to adopt and really live by the Lusaka agenda to really, Lisa mentioned, as you correctly mentioned, we need to abide by the country leadership, meaning that we need to focus on supporting the health systems that we're working with. So the technical leadership of the EWENE is very important because it provides the coordinated platform. And we are very much interested and open to partners who are willing to join us with quality assurance and respectful maternity care so we can work together on this. So let me stop at this point and I'll give you back the floor.
Okay, speaking of partners, Anna, I think an important partner is midwives, but I want to ask you a question first before I'm like accused of reverse sexism. Do we have any male midwives?
Yes, we do have
Really?
male midwives.
Okay.
Absolutely. And one country specifically that I know of is Malawi. They have a substantial number of male midwives. But I think in every country there are a few midwives, male midwives. I'm from Sweden, and I know back in the days we had 13 out of our almost 9,000 midwives. But that is the ratio we are talking about in some countries.
Okay, I don't know how I feel about that. Like, I'm just comfortable dealing with someone who's had a baby or at least understands some of these things. But anyway, I'll go back to the question that I initially I just mean, someone who understands how it all works or has experienced it. But how is midwifery helping further accelerate progress?
Absolutely, and male midwives more than welcome. We need to really work together through gender, also recognizing that the midwifery profession is a gender issue in the sense that 98% circa are women treating women. So having the whole gender aspect, so it was a great introduction into the midwifery profession in that sense. Midwives are one of the backbones in the healthcare system related to maternal and child health, including sexual reproductive health. So I think what has happened up until now is that we have identified a lot of evidence and built a lot of evidence since the Lancet series 2014 in the rationale of having well-educated, competent midwives well integrated into the healthcare system. We also are really emphasizing the importance of having an autonomous midwife. So we need to have a healthcare professional, the midwives, who can make the right decisions at the right time. And also very much work professionally with the other health-related professions, OBGYNs, the nurses, and the other health workers, such as community health workers. So midwives can provide today up to 90% of sexual reproductive maternal and child health services. However, we see that only 10% of them are utilized in the current situation. So I think coming back to what Ayman said about utilization of an effective health system, it is time, and given the geopolitical situation today, it is time to actually look a little bit more deeper how we can make better use of the different professions in the health systems to serve to a greater extent and meet the need of women and newborns, including sexual reproductive health.
Rhonda, yeah, definitely. Rhonda, so something that I'm quite passionate about is localization, actually. So how can a strategic, locally driven approach ensure that women's experiences and needs shape maternal healthcare policies?
Thank you, and good afternoon to everyone. Thanks for inviting me to be part of this very important session. I think a locally designed strategic approach that has worked for many years, and it certainly applies for maternal well-being, is the primary healthcare approach I was mentioned before. If you look at the area that I represent, the Americas, where we have diverse populations, we have countries as large as Brazil with millions of persons, and we have small island developing states with a population of 100,000. PAHO has been very adaptable to the country sizes and the particular needs of the populations in the Americas. We also have very diverse populations in terms of culture. And we have a lot of women in the Americas who belong to indigenous populations. And we have had to be very nimble using the primary healthcare approach to make sure that we really ensure that the policies that we recommend or that the policies that they adopt are culturally sensitive to those women as well. And looking at primary healthcare, again, affordable. We have women who are in they have socioeconomic problems, and we have to make sure that anything that we recommend that they are able to afford, it is affordable to them as well. And then finally, community participation. We have to listen to what women are saying and also make sure that we have some social responsibility in that we conduct audits at the community health level and at the hospital level to make sure that we monitor the services to make sure that they're adaptable and they are meeting the needs of women. So I think it's been around for a very long time, but primary healthcare always works if we were to apply it to situations, particularly with regard to maternal and child health.
Thank you. I think you raised something really important there, listening to what women are actually saying. And Ayman, how important are these, is this locally driven approach and listening to women?
Well, if we don't, then we are not going to be able to adopt a health system as simple as that. So it's very important, again, when we speak about collective or integrated health systems, or the health system approach. What is the health system? The health system, that is a system of multiple processes. And I don't mean to educate colleagues, they will know it more than me, for the ultimate outcome of improving the quality of lives of the person that we're serving. So if we don't listen to the needs, like the example, again, Lisa, that who I mentioned about women drifting away from a certain health center because of the lack of a commodity, then this is an indication that the health system failed. I give you a very simple example to this. We, again, going back to EWENE, we and UNICEF, UNFPA and UNICEF, we are the biggest procurers of essential maternal health medicines. Both of us, if I may come up with a number based on my memory, we're talking about $300 million of maternal health and contraceptive commodities annually, not talking about devices and everything. Buying these commodities does not mean that these commodities are actually making it to the last mile. It does not mean that they are actually going to be uptaken and used in the right way by women. So we need, in addition to what we are doing, and this is where an EWENE partnership comes in handy, where if we partner with all of our partners who are helping us with strengthening supply chains, with local distribution, with monitoring last mile uptake of these essential commodities and these essential services, we will prevent something like what Lisa has been mentioning, where suddenly oxytocin does not exist. So listening and making sure that we have visibility of what is actually happening. Are we answering to the needs of women? Are we serving them according to their needs? Are we abiding by their local cultural factors, their local geographic factors, rather than sitting on an ivory tower, thinking that the woman can walk 3 to 4 miles while she's in labor to come to my clinic? if we don't do this, and this backs us again to the Lusaka agenda. This is where local culture comes in very important, and listening to women becomes of the imperative to an effective health system.
Yeah, and I feel like midwives will probably be people who are much closer to communities. And I think there's an agreement that we're supposed to have this like locally driven approach. I know in a previous panel, someone asked who can say they're against global health. It's very difficult for someone to be like, I'm against global health, and it's probably difficult for someone to be say I'm against something that is locally driven. But are we actually seeing this on the ground?
Yes, we are seeing it because it is a gender issue, and women are, both midwives, nurses, and women as recipients of care are being down prioritized. And at global level, we are currently seeing that different areas are not competing, but yet competing with each other. So we need to support the dialogue to really bring women and the health workforce that provides for women at the top of the agenda. We shouldn't forget that 4 billion of us are women. 8 billion of us have been born by women. So it's highly relevant to each and every one of us, not only in this room, but all over the world.
Okay. So one thing we have here is a very diverse group of panelists, and I'm always curious to ask people, because like people talk about we work in silos. I'm always curious to ask people, how are you working together? And Ayman, you've talked a lot about that, but Rhonda, I want to first come to you. How can we then like ensure that first of all, like we're working together, we're collaborating, and we're also making sure that we're focusing on country-led priorities?
Sure. Yes, it's very important to ensure that you're working with the country and not imposing your policies or your plans with the country. And at PAHO, we try to do that. And you have to be very adaptive. For example, in some countries, maternal mortality might not be an issue. There may be zero maternal deaths. And I can say that in some of the small islands that I represent, PAHO represents, there are no maternal deaths. But we still have to do health system strengthening. And what we've tried to do, for example, is to find a topic that is relevant to that country, but at the same time strengthening health systems. For example, the elimination of mother-to-child transmission of HIV and congenital syphilis. That is something that has attracted attention, brought attention in a lot of small islands, because when we look at the EMTCT, the elimination of mother-to-child transmission of HIV and syphilis, you're looking at pregnant women. You're not looking specifically at maternal mortality, but guess what? You have to make sure that that woman comes into a health center at least 3 times during the pregnancy. And at that time, we not only do testing for HIV, but we also check their blood pressure. We check the hemoglobin levels, and guess what? Hypertension and bleeding is 2 of the main causes of maternal mortality. So by looking at one issue, we're strengthening health systems and dealing with maternal mortality indirectly. So that's one way of dealing with countries and making sure that they can indirectly tackle maternal mortality. Intersectoral collaboration as well. We know that I mentioned primary health care and looking at the socio-economic impact. We need to work with ministries of finance as well. And what we've taken it at a higher level at PAHO. What we've done, we're working now with the World Bank and the IDB to make sure that when countries get grants or loans, we're there with them to make sure that if a hospital is being built, what are the blood bank services going to be? If a hospital is being built, what is it being built in a place where women can have access to maternal and child health services? So it's not just giving money to countries, but also ensuring that the services are available. Health information systems. That's another area where we work with the banks to make sure that the services are really tailored to the entire population and specifically to women when we look at maternal and child health. And one more thing about access, I want to mention the PAHO's revolving funds. What we do is that we pool the resources of all our small countries to make sure that they get hypertension medication, laboratory products, for example, so that they can be used in maternal and child health services at a reduced cost to the country. That's another way we work with countries to make sure we improve access.
Wonderful. And Ayman, Lisa mentioned this really like striking example of a minister saying, if you're not going to prioritize our priorities, then please keep your money. Not sure how many ministers are willing to do that, but have you seen this happening more? And are you getting ahead of it to say, are you already thinking of like how to ensure that you're focusing on country-led priorities?
So, Rumi, there's the honest answer and there is the public answer.
I'll ask for the honest one for this conversation. We're all friends here.
Great. So, over the past 30 years of my career, this might have not been said openly because of reasons of diplomacy. But there has always been this issue of funding for healthcare, funding for global health. And funding means there is a donor and there is a recipient. And the recipient always needs to be respectful of the goodwill and the checkbook, if I'm being honest here, of the donor. So now, and I think we are in an opportune time now to start shifting our mindset from funding to financing. Because in financing, I'm going to be financing a health system. And for me to be able to be successfully financing the health system, it doesn't matter how much money I have in my checkbook. It depends back again to local leadership as to what is it that will actually achieve an impact. So instead of funding and instead of a donor recipient, there is mutual accountability between all parties. And this is where the donor contributes to financing the system. The relationship is built on mutual accountability because the local government is as accountable as the donor to delivering impact. So this, I'm glad that this now answer is becoming now out. If you're not supporting me, thank you very much. But believe me, many, because we still have financial difficulties. If I am in charge of a certain program in my home country and a donor is knocking on my door with a big checkbook, it will be difficult for me to turn them away. But at the same time, I do not welcome the fact that they come and develop parallel systems that may impede the effectiveness of my context-driven local health systems that deliver results of my constituents. So I believe that we need to learn from this, and we need always to focus on making sure that the right leadership and the right flow of financing, not funding, is towards health impact, which is measurable and that is built on mutual accountability.
Anna, I want to come to you because I think, we're agreeing country-led is important, but Ayman raised a very, 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 very important point that in addition to, in this like model that we're thinking about, there's also country responsibilities. How do we make sure that they're accountable? So first of all, with the country-led priorities, how important is that for you as an organization and a representative of midwives? And then in addition to that, how do we actually make sure that countries are also accountable when they're leading this?
It is a very good and very important question, specifically in these days where I heard Helen Clark saying it's a funding cliff. That is the magnitude of what we're heading into. International Confederation of Midwives, we are a 102-year-old organization, and we're a member organization, i.e. we have professional members all over the world in over 120 countries. And that is the key to what we see as a sustainable solution. That we have a midwifery association in each country who can speak for the profession, in our case, the midwifery profession, support the governments. They will stay and they will not leave, and they will grow in harmony with the development of a health system well represented, and also then looking at the reality of their midwives in that specific country. So we see that having the strong professional association in the associations, because we're also talking about OBGYN and nurses and others, pediatricians, that they are strongly represented in that, in every country, basically, to keep a sustainable development of their care to women in this field.
Thank you so much. And I think we've spoken about so many different elements that need to come together to make this work. But one question I have for all of you is, what is actually missing from these conversations, and what actions do we need to take? I'll start with you, Rhonda.
Thank you. I think if what is missing is, I think in a lot of the data, we don't analyze it to look at what's happening, the inequities, and to see specifically what's happening in some underserved population and in minority populations. And that's something that we've been trying to do. I think as well, what is missing is that collaboration with NGOs, greater collaboration and more collaboration with NGOs. For example, with PAHO, we collaborate with MSD for Mothers, and that has worked extremely well in Latin America. And I think more of that is needed with more organizations like MSD for Mothers. And I think as well, reorienting healthcare providers to make sure that we have women-centered health services, and it's not just a general population. I think that's important. What just looking back at the data and the gaps, what we've done in Honduras is that we've seen that with looking at the subnational level, you can identify areas within different population in different countries to see what is actually the cause of maternal mortality and address those specific areas. So I think that needs to be done in more countries as well, a deeper analysis of data to see where the inequities are, to see and to make sure that we really reach the women who need maternal services and make sure that the services that we provide are catered to their specific needs and the causes of maternal mortality.
And Anna, what's missing?
I concur to what Rhonda said about partnership. I think that is absolutely crucial. And we have, as Ayman said before, also looked more into depth. What does partnership really mean in terms of roles, responsibilities, accountability, and other things? So partnership and harmonization of different initiatives, I think, is extremely important. I would also say that being a midwife, not being a financial person in any way, we have to look into the return of investments in where the funding that we do have and how the governments are supported in making those decisions that's best for the country. We know, for example, that there is a 16 times return of investment in a midwife. So having those discussions and to support the governments and link the Minister of Health with the Minister of Finance, for example, that is to even greater extent to what we do today. I think it's really, really important to give the best that we have together.
Thank you. Ayman, same question.
Thank you. And thank you, Anna, for mentioning investment. What I would answer briefly is, it is a business. We are in the business of saving lives. So let us adopt a business mindset. And the business mindset means that we collaborate, we are interdependent, we do not compete, and we aim at measurable outcomes in terms of number of lives saved, number of women who are living a healthy and happy life. We are not only about saving lives, because maternal morbidity, and we were discussing this yesterday, it is so much rampant and it's covered and it's overshadowed by maternal mortality. So my simple answer to you is, let us develop a good business mindset, working under a partnership like EWENE to support one single maternal, newborn and child health acceleration plan at the country, where we all collaborate to implementing it, identifying each one's relative advantage or specific advantage in contributing to achieving this plan under the leadership of the local government that we are serving.
I actually love that, looking at it as a business, because that immediately brings accountability and results into it, because you're looking at it as a business. I'm going to cede the floor. I'm going to cede the mic to the floor and ask if anyone has got any questions. I think I have room for about 3. If you lift up your hand, someone will find you with the mic. We have one right in the front here, one in the middle, and one at the back. A mic is coming soon. I have one here if we don't.
Okay, thanks so much. My name is Estana Sike. I lead advocacy for maternal, newborn, child health and immunization at PATH. And mine is just a comment, because I also support advocacy under the EWENE initiative. Mine is just a comment to say, everything that has been said up there is important, but I think what we are forgetting is that the political arm does make decisions around how countries are investing resources. So part of what is missing is making sure that we have the political wing on board, because they determine what we are allocating and where. That's why in the region, in the Africa region where I come from, I'm from Uganda, you'll see so many countries have big budgets for defense, but they still know that women are dying. They still know that we need the HR, we need the commodities. So that's important. And lastly, how are we communicating these messages in a way that helps the decision makers to actually make those important decisions? It's easier to say oxytocin, but your politician will not understand what oxytocin is, or misoprostol, or whatever it is. So let us translate this in a way that helps the decision makers to make decisions, but also empower the technical teams within the ministries of health to be advocates for investment at country level, because ministries of education have been affected, agriculture have been affected, but how are we equipping the technical teams within the ministries of health to be advocates for investment at country level? Thanks.
Thank you. We have one in the front and there was one in the middle somewhere. Here it is. We'll start here.
Thank you very much for that very lively conversation around maternal health. I'm Adeze Ore. I was Commissioner for Health in Rivers State in Nigeria. And one of the things that came out in the work on maternal health was about engaging with community and traditional birth attendants. And in the spirit of collaboration and non-competition, I wanted to ask how a lot of the work, maybe in EWENE and any of the other initiatives, has engaged these community and traditional birth attendants, which we know are often feel neglected in orthodox medicine, but resonate very well with community members who feel respected and culturally identified with such attendants. So if you could share those experiences with us. Thank you.
Thank you. We're going to take one more, like in the middle there.
Hi, I'm Viviana Martinez Bianchi, President-elect of the World Organization of Family Doctors. I think we are a group that often doesn't get brought into these conversations. As a family doctor, I was trained in obstetrics. I did rural medicine in the United States. And I see this also, that family doctors in several countries are part of the obstetrical care, the prenatal care, the delivering of the babies, and we sometimes forget to equip those primary care teams and family doctors with the training and the support to continue the type of work. I just wanted to know if the panel has any thoughts about how to bring us together into these conversations.
Okay, thank you so much. I'm feeling like maybe we skipped this side. Did anyone have a question from this side? I'll take one just to be fair. Okay, that's good. Okay, so okay, I'm going to start with you, Anna. One question was around community and traditional birth attendants. Are we including them in these conversations, and how can we be more inclusive?
Thank you very much, and it is a very important question. I would say that at national level, the discussion on TBAs, it's there, in the sense that recognizing the importance of having TBAs in the community already, having a trust from the women and from the community, but also linking the TBAs and their knowledge with more and more increasing numbers of midwives, so that the TBAs and the midwives work together. I think that's absolutely crucial, and that will help the TBAs in their care and refer to the women, to the midwives when needed, and also give the midwives a chance to know what's going on in the community. So we have again to look at the roles and responsibilities quite carefully, but very welcome to work with TBAs, identifying roles and responsibilities. If I may just also respond to the advocacy question, because I think it's a very valued question. ICM, we have quite a revamped campaign called the PUSH campaign. And if you think of a midwife, woman giving birth, PUSH, it's a push campaign which really speaks for the women, by the women, of what the women want. So please go online and look at the PUSH campaign. We are really, really together, midwives and women, to put much more strength into the collaboration between women and midwives. Thank you.
I'm curious about something. I thought about this when you're talking about TBAs. Do we have any programs where we're providing training for TBAs or where there's knowledge sharing? Have you guys come across any of that knowledge sharing between maybe doctors or midwives and TBAs? Have you guys come across any of that?
I worked in Bangladesh 15 years ago, and there were a program working with TBAs, trying to educate them into a skilled birth attendant, working in the community. And we saw the evidence was that they didn't require the competences that we know are life-saving. So instead, we discussed with the government to link the TBAs more to the growing number of midwives. So recognizing them, but also recognizing that we need a stronger, competent cadre of midwives well integrated in the health system.
Rhonda, I feel like you want to jump in.
Yes, because in Latin America, we do have a lot of TBAs, and we do facilitate training with TBAs and between the TBAs and obstetricians, and they learn from each other. So it's something that it's seen, and it's something that POWER facilitates in Latin America, where we have a lot of rural and indigenous communities.
Thank you so much. And Rhonda, I also want to ask you this question about how can we be more inclusive with family doctors? And then in addition to that, someone spoke about political will and how important that is. Are you seeing more political will?
I think I'll start with political will. I think, yes, we are seeing more political will. We need to do more. But I also think to go further with political will, we have to empower more women to become involved in politics and have a voice. And even if we have women when we have women at a community level, make sure that their voices are heard, so that the politicians listen to them and they design their policies and implement policies according to what the women actually need. In terms of family doctors and getting them involved, certainly not all maternal needs necessitates an obstetrician. It's a specialized area of medicine, and family physicians do have in fact, some countries have family physicians as specialists, so they do have a very critical role to play. And imagine a woman having a family doctor who she's comfortable with. Of course, that person should be able to look after her family and her newborn.
Ayman, same two questions on political will and inclusivity.
Okay, political will. First of all, the light in my eyes is a good test if I have cataract or not, and I don't. It's very, yeah, I'm glad my lenses are fine. So because I can almost not see anybody. So political will, if we just decide to take a walk and go meet the ministers of health and ministers of finance in the area, and we ask them, do you care about the lives of women in your country? I don't imagine anyone is going to say, no, I don't care, let them die.
And if they do, we can tell their mothers.
So the political will, there is a difference between the political will and the actual conversion of this will into policies, regulatory policies, fiscal policies, and the service delivery policies that convert this political will into actual reality. And to my mind, this is the gap. So I can have all the good intentions. I'm sitting on the budget of my country. I am Minister of Health, Minister of Planning, Finance, whatever. I have all the good intentions. But now I'm in the time where I'm going to set how much money is going to be put in the public health budget that is going to be allocating X% of it to train midwives in this particular state, in this particular community. This is where the gap is, and this is where I feel And this is something UNFPA has been working very hard on, introducing what we call smart advocacy, meaning that we bring the data that are required for these policymakers to shift from just their political will into having the information that they can make an informed decision when it comes to enacting and developing these policies. This gap is still missing. And we as a partnership, as the EWENE partnership, we need to work together into taking this political will, which is it's a good notion. It will not take us anywhere unless and until it's converted into these policies that we can implement, measure, and get back with an impact.
Thank you so much. And final question, sort of for you guys to share your final thoughts. We don't have much time, so really quickly, final question, and I'm going to start with you, Anna. How can we ensure that women's voices are heard, prioritized in maternal health decision-making processes?
My response to that is to ensure that every woman have access to a competent and well-educated midwife all over the world. And we know that that will save 4.3 million lives per year, including newborn and stillbirths. So that is a complete dream, that every woman have access to a midwife who will listen to her, give her time, provide her with the services that she needs at that very point.
Okay, and Rhonda?
I think we need to continue talking about maternal mortality and saving women. For us, such as these are very, very important. It seems sometimes that we keep saying the same thing, but I think reinforcement is good, and I want to thank the organizers for organizing this very, very critical and important session.
Ayman?
Educate girls, educate girls, educate girls, and empower them to be an active member of the labor force of their society so they could be heard.
Thank you so much. That's a strong end here. We're not done. You guys can stay here. I'm going to call upon on stage one more person. This is Enas Osama, who's the liaison officer at the International Federation of Medical Students and Associations. Enas is going to give us a wrap up.
Good afternoon, everyone. Thank you so much for having me today. I would like to express my sincere thanks to Devex and all the organizers of this important event, and for the depth of insight and commitment that you have all brought to today's discussions. I would like to introduce myself. I am Enas Osama, a medical student from Sudan and the liaison officer for human rights and peace issues at the International Federation of Medical Student Association. And today I do not speak only from a professional lens, but a lived reality. Over the past 2 years, my country has endured one of the most devastating humanitarian crises in history, and we have seen health system collapse under conflict, hospitals being attacked, and maternal care was pushed to the brink. But today, as the war seems to hopefully be approaching its end, we must look toward post-conflict recovery. And maternal health needs to be at the heart of the rebuilding, because when a mother is forced to give birth without skilled care, and when there is obstetric violence, we are not just witnessing a health crisis, but a failure to uphold and protect human rights. In our journey toward recovery, midwives are our hero, and we must champion them if we hope to see meaningful change in the quality of care that we can provide mothers. Midwives do not just deliver baby, they deliver dignity, safety, trust, especially in low resources and crisis affecting settings. Maternal and newborn health is essential to well-being. Equitable access to these services is key to peace processes. That's why what we have here today matters so much. And we youth are more than future professional. We are the present change maker across IFMSA. We are educating peers on safe motherhood, running community campaigns, and advocating for inclusive, youth-friendly health system that serve the adolescents, the girls, people with disability, displaced populations, and all vulnerable communities. And we understand that maternal health is about justice, equity, and the voices of vulnerable groups being heard. And voice is what we demand. We demand a seat at the table as equal partner. We bring fresh perspective, lived experience, and unwavering commitment to SRHR, human rights, and to systemic transformation, and our participation must be sustained, structured, and strategic. As I close, I invite us to remember that behind every data is a story, behind every policy is a person, and behind every future is a choice we make today. Thank you.
Thank you so much. Thank you so much. And I think that just indicates why it's so important to include young people in the discussion. You're a perfect example of why this is so important. And to my panelists, thank you so much for joining me. I am releasing you and handing over to Kate.
Great. Well, thank you. Thank you, Rumbi, for expertly moderating these conversations and our panelists. And thank you to MSD for Mothers for being such a valuable partner to us and bringing this conversation here, both in person and online at WHA. We appreciate those of you who've been with us all day or just for this conversation. Thank you for joining us. We will be back in this same room tomorrow morning, starting at 8:30 for another full day of events. So please come back and join us. And you can check out the agenda online to see all the exciting conversations we have in store. But in the meantime, thank you, and thank you to MSD for Mothers.